So immune-related adverse events are actually not very common, especially for the grade 3 or 4 adverse events. But if and when they do happen, some of them can be really life-threatening. And therefore, it is a very important concept to know for both physicians and patients alike. So we often emphasize this to patients that anything can happen, actually any autoimmune related adverse events, including autoimmune hepatitis, autoimmune colitis, autoimmune nephritis. So any organ, in fact, would be at risk, and even like nephritis. Now, as a general rule of thumb, what I often, tell patients, and other physicians, whenever we encounter any toxicity that could be autoimmune related, one of the things we always want to do is rule out, other infectious causes or any other cause that would, explain the toxicity. So for instance, in a patient who develops renal dysfunction, was there a recent contrast use? Is there acute kidney toxicity because of the use of antibiotics? Is there dehydration? So ruling out other causes. So for instance, for colitis, we want to make sure that they don't have any infectious causes of colitis. Same thing with hepatitis. Do they have viral hepatitis? So all of these things, once we've ruled them out and there's no other good explanation other than autoimmune cause, we also need to determine how bad is it? What is the severity of the grading? And again, we often would go back to our primary source and look at our toxicity grading book. But at the same time, there's, again, general rules of thumb. So if a patient develops grade 1 toxicity, usually they're asymptomatic. And for instance, for autoimmune hepatitis, there's also a lab abnormality. And as long as, your AST and ALT are less than 3 times upper limit of normal, you can choose to keep the patient on the immunotherapy and very closely monitor. But the moment you hit a grade 2 toxicity, that warrants stopping the drug, at least temporarily. And then again, initiating all the workup and also instituting steroids, because that's an essential part of the management of any immune-related toxicity. And we usually use prednisone or its equivalent. You can start with 0.5 milligrams to 1 milligram per kilogram dose per day. And then you escalate, especially if a patient does not respond within 3 to 5 days, then that may be a trigger to escalate your dose of steroids. And in some cases, even like, let's say, autoimmune colitis, you may take it up a notch by giving them additional immunosuppressive drugs like infliximab, for instance. Or in autoimmune hepatitis, you may choose to use other immunosuppressive drugs like mycophenolate, for instance. So a lot of this is also the idea and the option of engaging all of your other specialists. So for instance, engaging the GI doctors for autoimmune hepatitis or colitis, engaging the nephrologists, when you have renal dysfunction. So those are the key management. And whenever you see grade 3 or 4 toxicity, that's an indication usually of stopping it completely and perhaps never going back, depending again on the toxicity, because one cannot risk having a re-challenge, sort of toxicity once you give the patient the same drug or even a different drug of the same class.